Welcome everyone to another episode of CRA Arthritis, this year taking place in Quebec City. It's the 9th consecutive time ACE has run this program with the Canadian Rheumatology Association and Arthritis Health Professionals Association of Canada. And we're very pleased to have a repeat guest with us, someone I think a lot of our audience will know, and that's Dr. Carter Thorne, a leading researcher and rheumatologist based here in Ontario, based in Ontario, not in Quebec, but in Ontario. And today we're going to talk about a couple of the roles, a couple of the hats that Dr. Carter so adeptly wears, and that is, first of all, as a member of the CRA and one of the pioneers of the CRA and leaders. The CRA is divided into a number of working committees, and Carter is the leader of the Stakeholder Engagement Committee, which is a lofty sort of name. And maybe to start off, you can tell us a little bit about what stakeholder engagement means for the ORA and what you guys are doing.
Thanks so much. Well, what the CRA is doing is taking advantage of my long-term relationship with the CRA, but also our constituency, and then also our partners in patient groups, partners in industry, partners in regulatory authorities. And most recently, my activities have actually been with Health Canada during time of COVID. And many of your listeners will be aware of the challenges we had with Plaquenil when it was being touted by other folks, as well as some other medications. In this interval of time, we've had problems with methotrexate availability, some steroid availability, and Actemra and tocilizumab availability. And I really got some great news about our collaboration with Health Canada and with industry in ensuring that patients continue to have access to their medications.
I certainly know from experience that Health Canada is very familiar with Dr. Thorne, and it's almost a second home for you, isn't it?
It is, yeah. We were able 5 or 8 years ago to ensure that our pediatric patients were able to get naproxen suspension. That was our first foray in working with Health Canada, working with industry, and to get something for our constituency that was really relatively small and not of much interest to larger parties, but great interest to ourselves. And then we were able to, again, work with another company to get a long-acting steroid injectable preparation, which had gone off the market, but which our pediatric colleagues really found very successful for the young patients because it lasted much longer than the usual product. So I've started using that product as well because it works for patients who respond to injections but don't have a durable response. So that was really successful, again, working with Health Canada to facilitate it coming into the country. And then more recently, we had some challenges with methotrexate, access to it, and then more importantly, we'll talk the platform out, but one of the most fulfilling interactions we had was with tocilizumab and Roche, who let us know back more than a year ago, that there was that this product was becoming very popular in a good way, as opposed to Plaquenil, was very popular in the critically ill patients. It made a life-supporting difference, but that was potentially could take away from our own patients. So we worked with the company in Health Canada to ensure that there was a continuous supply. It was variable. Sometimes it was injectable or sometimes infusion, but I don't think any patients missed out on getting their tocilizumab. And so I hope that patients actually never knew it was happening. It was just seamless. That was a really successful success story. So now, to your point, I now have a regular discussion once a month with folks from the Drug Shortages Division of Health Canada, talking about issues related to our needs in the community. So again, that has built on that success.
We know a lot about the work that you do. We know how important the patient perspective is in the work that you do and how well you represent it. But we also, not just ACE, but a lot of the patient organizations in Canada have great experiences working with you too. So we consider you a patient advocate as well, and we really, really appreciate the work you do in that area.
Thank you.
We're going to maybe flip over now to the CARE program.
Mm-hmm.
And certainly our audience may be familiar with the Arthritis program, as it was called, its predecessor was called, which closed its doors, I believe it was at the the end of 2020.
We were notified in September, closed in January of 21.
And it was another opportunity for you and some of the other leaders, healthcare professional leaders in Ontario, to work together with patient groups. And we worked really hard together behind the scenes, appealing to the government to do the right thing and to continue the program. You've got some really great news because it's up and running again under the CARE acronym. Can you tell us a little bit about
Absolutely. So the arthritis program was funded in 1990 as a regional arthritis program by the Ministry of Health within a hospital environment, because that's what we did back in 1990. It evolved from an inflammatory arthritis program to one that covered MSK, or musculoskeletal, inflammatory, osteoarthritis, osteoporosis, chronic pain, fibromyalgia. It also had an early arthritis clinic. It had other components. So it was a full service. We called it a portal of care. At the same time, we embedded research in TAP as well. So we had the Canadian Early Arthritis Cohort Catch, which was a really very strategic development because we were able to count how we were doing. So we were closed, not by the ministry, but by the hospital. They decided that we weren't fit for them for whatever reason. And when that happened, which was in September, I said, this is not right. And again, as you've indicated, we had a long relationship with patient groups. So we actually brought together information from research, CATCH particularly, information from research, making use of one of our colleagues, Jessica Whitfield at the Institute for Clinical and Evaluative Sciences. We got together with the patient support groups, patient advocacy groups, not just around us, but across the country because of our linkages. And I think that we were able to demonstrate to the ministry not only our passion, but also the cost effectiveness, how we made lives better for patients, not by spending more money, but by spending more time. So the patients got better. And our cost avoidance in our program, we could demonstrate, was between $2.5 and $5 million, which is a heck of a return on investment of approximately $1 million or less. So I think the combination of the advocacy support that we had from the patients, patient voice, the advocacy we had from research, like real stuff, it wasn't just numbers of patients going through, but actually cost effectiveness, and then the commitment that we could deliver that portal of care. And so the Center of Arthritis Excellence is a not-for-profit, outside the hospital community group whose mandate is to supply the services that we had with the arthritis program, but now in a community context. So we have an independent board of directors. We have a new facility in the same building, but a new facility, purpose-built, not what it was before. It's really up to snuff and got a whole new group of people, which has been a challenge because we had a very excellent group before, but it's up and running now finally.
It's a model not just for Ontario, it's a model for the rest of the country. There are similar types of centers and sort of community care across the country, but this really is a best practice, Carter. And maybe for our audience, I mean, what distinguishes it obviously is just how effective the I think you call it interprofessional or interdisciplinary approach is. What is that patient journey or patient experience if they walk into care? What is that experience like?
So we've always been driven by that final clinical outcome, that journey. How can we make it better? And I like to tell the learners that come to us that we start off with trials of N equals 1. Each person comes in, and we're going to get you the best you can be. And then we bring that together, the larger group of that community, and larger again. So the journey is, we can tell you from the ICES data, which shows that in Newmarket, which is north of Toronto for those who don't know, our catchment area is approximately 250 kilometers, so 2 to 5 hour drive. So it's kind of rural, kind of suburban, kind of urban, has all the components. We don't really look after Toronto or South York region. So we're looking after that larger population. But even with that larger catchment area, I should say, we can tell you from the ICES data and the CATCH data, we see patients sooner from symptom onset. They start treatment sooner from diagnosis. and they start showing change and improvement sooner than the catch cohort in general. They get better more completely with less medication. It's phenomenal. And in the catch cohort, I believe not only because of the medications we use and the way we use it, but because patients are engaged with their care. They learn how to look after themselves. We're partners. And in our rheumatoid arthritis cohort, 20% of patients are in a medication-free remission.
Fantastic.
And the average 60 years.
Yes, absolutely.
Yeah.
Yeah.
And that's the result of patients making a difference, and that's being able to help them end that journey.
Well, we're obviously so pleased that the story continues under a different name. And I think we just want to say, too, how much we appreciate all the work that you've done on behalf of patients and continue to do in Canada and in particularly in Ontario. So thank you very much for joining us again, Dr. Thorne. You're always welcome.
Kelly, thank you so much. And remember our tagline, a local program, a national resource.
I will remember that. Thank you, Carter.
Thank you.